So if I start with the introduction about inborn errors of metabolism, they are rare disorders. If we talk about specific individual disorders, they are very rare. However, if we club them together, it comes to around 1 in around 2,500 live births. The problem with inborn errors of metabolism is that they are very heterogeneous. They are different disorders. Every disorder is different with a distinct epidemiologies, different presentations, different genetics. They have a variable genetic expression. So you may have a gene which may have complete expression or incomplete expression or complete dysfunction of the enzyme. And all neonatal screens do not diagnose the inborn errors of metabolism. The screens which we commonly use in our countries, they just identify only a few of these inborn errors of metabolism. Moreover, to add to these, the timing of the neonatal screen does matter. If you do a screen too early, you may not be able to diagnose the inborn error of metabolism. And if a child is transfused, then also we may have false negative tests. Next, please. So Rupesh, yeah, go ahead.
So the way the structure of the talk is, we'll have a case, and this is a real-time case, and then we'll try to give you some insight about the approach of the diagnosis and various modality. So you're called upon for a patient who was a smaller of a pair of a twin delivery by 24-year age of primary gravida at the outside of the institution because of the twin intrauterine growth retardation. Labor was induced at 36 weeks of gestation. At birth, he weighed around 3 pounds and 9 ounces. Over the first 9 days of the life, he required IV glucose in addition to his isomil feed to maintain euglycemia. He was switched to breast milk on a day 9 and subsequently developed feeding intolerance and emesis. On day 10, he became lethargic and developed a strong body odor. Laboratory tests revealed mildly elevated serum ammonia of 206 millimole per liter with no acidosis. The next day, he got more worse. He was getting more progressively lethargic and subsequently went into coma. His serum ammonia at that time was 1,396 millimole per liter, and there was no acidosis. At this time, he was transferred to our hospital. Siddharth.
So the question is, when do we think about metabolic disorders? So especially if a child is apparently normal for a while and then you see sudden deterioration. So which may suggest that there was an accumulation of a substrate and this child was slowly progressing into that accumulation of the substrate. So that's very important. Consanguinity is important because most of these disorders are autosomal recessive, and we know consanguinity precipitates the autosomal recessive traits. Acute unexplained illness. So if you have a child who is not having sepsis and he's sick, we should think about metabolic disorders, unexplained encephalopathy, cardiomyopathies, persistent severe hypoglycemia, needing a very high glucose infusion rates, unexplained liver failure in a child, unexplained metabolic acidosis, and we'll be talking about high anion gap metabolic acids today. A peculiar odor to the urine or the body is also a marker to think about a metabolic disorder. Next, please. So what are the differential diagnoses when we think about inborn errors? And we should think about urea cycle disorders, organic acidemias. So these should be the differential diagnoses in our mind, looking at fatty acid oxidation defects, mitochondrial disorders, transient hyperammonemia of the newborns, which is common in preterms, but it can be sometimes presenting as a very severe illness. Severe birth asphyxia can also present in the similar state due to the increased protein breakdown during the hypoxia and associated liver damage. Liver failure in infants can also present in similar fashion because of the multifactorial etiology. In fact, adding to that, there is septicemia in these newborns, so it may also look like inborn errors. Next, please. So what are the clinical presentations? And they are varied. Can we go to the next slide, please? So there are varied presentations, and presentations can be just an encephalopathy with unexplained metabolic acidosis. So organic acidemias, UCDs, congenital lactic acidosis, they may present with unexplained encephalopathy and unexplained severe high anion gap metabolic acidosis. On the other hand, they may present with liver disease, a child presenting with unexplained infancy liver failure like galactosemia, tyrosinemia. They may present with liver failure in infancy, unexplained neonatal cholestasis, say alpha-1 antitrypsin deficiency presenting as neonatal cholestasis, unexplained severe hypoglycemia. Dysmorphic facies can also be a clue, which may be seen in peroxisomal disorders, lysosomal disorders. And Rupesh has a lot of experience of seeing children with CDGs, congenital disorders of glycosylation. They may have unexplained cardiomyopathies, as seen in fatty acid oxidation defects, glycogen storage disorder type 2, like Pompe's, and mitochondrial disorders. Next, please. So, what are the clues which may help you when you see a child with suspected metabolic disorder? You may have a child with coarse facies, which may be seen in lysosomal disorders. Unexplained cataract with liver failure can be galactosemia, Zellweger syndrome. Retinitis pigmentosa is seen in mitochondrial disorders. As pediatricians, we are all aware about differentials of cherry red spot, differentials of hepatomegaly, organomegaly with suspected metabolic disorders. Eczema, alopecia may be seen in biotinidase deficiency, which may be also picked up on neonatal screens. And they may have pigment abnormalities of the hair or the skin, as seen in phenylketonuria. Next, please.
So how would you approach the IM? And this always happen in my world is when it's a Friday weekend is coming in and you get the patients. So if you look into these kind of differential diagnosis of inborn error of metabolism, it's very complicated because you need to have a genetist, you need to have a comprehensive care team to assess. Some of them, which are very common, are the carbamyl phosphate synthetase deficiency, OTC, or ASS deficiency, which is citrullinemia. You can have arginosuccinyl aciduria, you can have arginase succinate deficiency, or you can have NGAS deficiency. This is a nice paper that we published, which is a consensus guidelines from the PCRRT, and we're very proud to kind of lay down the statement. And I will highly recommend all the fellows to read it because the authors are, some of them have actually been the discoverers of the OTC and urea cycle disorders, and it has been laid down very well. And this will be your baseline structure to guide you with the management. Now, this is a very important algorithm that you need to know is if you have a symptomatic newborn, which I gave you a scenario, just within 2 days, his ammonia level was like almost 100 what he was initially. You need to have a plasma concentration of the ammonia, and you can see his level was 150 micromole per liter at that time. Nothing was done. By the time he came to us, it was 1,250. You always obtain an anion gap plasma glucose concentration. If you have a urea cycle disorder, the anion gap will be less than 20, which is normal, and plasma glucose concentration should be normal. Now, I will hold on that. I will move to that algorithm later. But if you have other metabolic disorders, anion gap is greater than 20, and you have hypoglycemia. What are the differential diagnoses at that time? You obtain the urine organic acid, you do the plasma amino acids, or you can look into the acyl carnitine profile. So if you have a urea cycle disorder, you will have a normal anion gap. Your plasma glucose concentration should be normal. But if you have other metabolic disorder, your anion gap is higher and you have hypoglycemia. So let's go over with the primary urea cycle disorders. When you have normal anion gap and you have normal glucose level, then you obtain the plasma amino acid. It takes a little bit of time to get it back. But if you have low citrulline and arginine plasma concentration, you go for the orotic acid because then you are looking for CPS1 deficiency or NGAS deficiency, or you're looking for OTC deficiency where you have elevated urinary orotic acid patient. And actually, I have one patient recently was diagnosed with the OTC with a similar algorithm, and his anion gap was normal, no glucose issues, and he has low citrulline and arginine. By the time we got that, we didn't even go for urine, and we knew this was an OTC deficiency. If you have high citrulline plasma concentration, then you look for arginosuccinate deficiency, and the way you do it, you do the fibroblast enzyme assay, or you will look for ACL deficiency where you have elevated arginosuccinate. In ASS deficiency, you have negative. When you have a markedly elevated plasma arginine level, then you confirm arginase deficiency with the red cell enzyme assay. I want to be very clear here. These are the confirmatory tests, but this is a good algorithm for you assessing the plasma amino acid in the setting of the plasma urea cycle problem. I don't want to go into detail, but just to say this is an involvement of a complex process which involves mitochondria, transition or transformation or transitions from cytoplasm going into the liver, and some of them are aspirate, going to arginosuccinate, to arginine, to ornithine, and then ornithine goes inside the liver, and then it converts into citrulline, and then some of them combine with carbonyl phosphate, and you can see the deficiency. So this is just an algorithm to tell you what are the things you are focusing when it is a mitochondrial disorder or in the liver, and those are ornithine, citrulline, or carbonyl phosphate deficiency. But what are in the cytoplasm is the aspartate, arginosuccinate, and arginine, and the urea. And that's why the algorithm, which I showed you before, is very, very important diagnostic marker to look when you're making the decisions on the clinical ground. Now, this is a nice consensus statement diagram, which actually shows and depicts the same transformation. And it is very complicated. It took us a lot of time to put this diagram in. But I think going back to my original slide, you need to know what are you targeting in the liver, what are you targeting at the plasma. So easy and simple. This is what I want you to know when you have a time, you have to decide, you have a blood gas. If you have a metabolic acidosis and you have elevated ammonia, your differential is organic acidemia, methylmalonic acidemia, propanoic acidemia, isovaleric acidemia, fatty acid oxidation defect. But if you have normal serum ammonia, but you have metabolic acidosis, it is MSAT. And I have diagnosed one case of the methylmalonic acid just looking at the elevated ammonia and metabolic acidosis. When you have normal ABG and you have elevated ammonia, then it is urea cycle defect. And I told you the iron gap is normal in a urea cycle defect. You don't see any glucose involvement, but you have normal blood gas. You have a normal serum ammonia level. You're dealing with non-ketotic hyperglycemia and galactosemia. If you don't want to carry other differentials that I gave you, this is your good index card to walk in or when you would call upon to assess these patients. These are some of the tests that we put in. What are the first line investigation in neonate? What are the second line investigation? This is just for your take home messages. But initially you do the blood count, you do liver function tests, renal function, blood gas, and iron gap, glucose, lactate, ammonia, urine for ketone, and urine for reducing substance. These are easy, short turnover. But if you go into the second subset where I was giving you an algorithm, you could look into the serum amino acid, total and free carnitine, acyl carnitine profile, but these all take more time. And if you really want to label the diagnosis, now here you need a role of the genetics because they will tell you what is the confirmatory test for these kind of disorders that we are dealing with. But this is a good handout for the first time when you have this patient you're dealing. These are the first preliminary test is very, very helpful. And some common metabolic causes of the neonatal encephalopathy and key test you need to know very well. Urea cycle defect, organic aciduria, MSUD. And again, going back to MSUD, this is the one which does not have acidosis, but you have acidosis, but ammonia level is normal. Non-ketotic hyperglycemia is a condition where you have normal ammonia, no metabolic acidosis. So these are some of the confirmatory tests that are very, very important. Now, I will defer it to Siddharth to tell about the epidemiology and KRT in IEM. Siddharth.
Yeah. So our theme of the day is talking about KRT in these metabolic disorders. So we will be talking and taking you all towards the KRT modalities and the epidemiology. So next slide, please. So this is a very important study because as these are very rare disorders, and I think all of us who are seeing these rare disorders, it is very important for us to publish our experience. And this is a very nice study from US where they looked at 9 hospitals across the country and they looked at their experience of 51 neonates in the last 15 years. The median age at admission of survivors versus non-survivors was the same at 3 days of life. Now, what they showed was that the most common modality which they used in these babies with IEM was hemodialysis. And if you look on the right side, they showed how their knowledge progressed over the last 15 years. You can see dark triangles here. These were children who did not survive, and they were put on hemodialysis initially. And then as we learned that CRRT could be a better modality for these babies. And if you look on the right side, you look at 2010 onwards, they started using more of CRRT in these babies and survival improved, and not many babies did receive hemodialysis. So when they adjusted the clinical factors, renal dysfunction, vasopressor requirement, degree of hyperammonemia, the hazard ratio for death was maximum with hemodialysis at the onset. And we'll talk more about hemodialysis. So the hazard ratio was 4. Next, please. So they made an excellent model, and they looked at what were the variables which helped them to decide which baby survived, which baby did not. And if you look here again on the top, hemodialysis had the p-value was almost reaching significance. If you go down, you look at any number of complications in this baby. The number of complications, each additional problem added almost the risk of death by 542%. If you look here, if you go down to the last sentence, 100-unit increase in ammonia was increased, associated with 3% increase in the odds of death, though it was not statistically significant. So this study did talk about maybe hemodialysis, maybe CRRT should be a better modality to start with. Can you go to the next slide? And if you look at this study from Torino, Italy, where they looked at their last 10 years experience of RRT in neonates in IEM. They looked at 12 babies, and they showed whatever modality you use, the survival was in fact better in these babies. All babies survived quickly. They all responded to RRT, even if the ammonia was high. So if you look on the right side and you look at the straight lines are survivors and the dashed lines are non-survivors. You can see that children, in fact, who responded early, they survived, irrespective of the pre-treatment picture. So maybe what we want to highlight is the early response is also a predictor of survival in these babies. Maybe it's not all which modality is better. Maybe it's about who responds early. What is the duration of coma in these babies? They are better predictors of mortality in these babies. Can we go to the next slide? So we as a team, the PCRT Iconic Group, and thank you Rupesh for leading this very important meta-analysis on KRT in inborn errors of metabolism. And this just published almost a month back in Kidney Medicine, and all of you can access to this proof in Kidney Medicine Journal, where we looked at 249 articles, and we finally looked at 14 studies published after 2000, which met the inclusion criteria. And this is in fact the largest meta-analysis of KRT in IEM, 231 babies, and you can see the spread of the IEMs here with a mean age of 2.3 years, ranging from 3 days to 12 years. Next, please. And we showed here, you can see on the forest plot on the left side, and if you look at the total effect, you can see the survival in these babies was around 50 to 60%, which is seen in most of the studies. And if you look at the right side, you can see the ammonia at which they presented. And if you look at the total effect of the total ammonia at which these babies presented to different centers, was again almost more than 1,000 level when they thought about starting KRT, which may be quite late. Next, please. So if you look at the survival and you look at the overall survival in these 14 studies, 231 babies, if you look at the first sentence, the overall survival was 63%. And if you look at the second sentence, age more than 0.7 years, the survival fell down to almost 60%. And this survival is also comparable to all the studies from United States as well. So it's not about which country, where are you from. The survival in these babies does range from around 50 to 60%. Next, please.
So, what is the clinical presentation of inborn error of metabolism with an hyperammonia? And you need to know that hyperammonia is defined as more than 100 micromole per liter, which is 170 microgram per deciliter in neonate, or more than 50 micromole per liter or 85 microgram per deciliter in term infant, children's, and adolescents. And this criteria is very important. Again, going back to a consensus guideline. So infant with hyperammonia presents with lethargy, hypotonia, and tachypnea. Ammonia levels more than 150 micromole necessitate further diagnostic evaluation. And the worst outcome, which Siddharth already presented in our systematic review as well, is associated with persistently elevated ammonia, which is more than 800 micromole per liter for 24 hours of prolonged coma. And that's what he was saying. It's just the initial response, how they present the morbidity and mortality down the road. And prompt treatment is critical because you want to clear the ammonia and minimize the morbidity. Now, these are some of the early symptoms in infant, children's, and adults, because if you look into the neonate, they just present with a very non-specific presentation like poor feeding and vomiting, lethargy, somnolence, irritability. You may see sometimes hepatomegaly because of the decreased urea production and increased hepatic enzyme. But sometimes you see a lot of worsening symptoms of respiratory distress and tachypnea, which was in our case. Hyperventilation and respiratory alkalosis. Keep your mind open if you see these kind of deterioration, hypothermia, hyperthermia, hypotonia. And this has exactly happened in our patient too. Some of the life-threatening symptoms you have to be careful is acute encephalopathy, cerebral edema, seizures and neurogenic posturing, peripheral circulatory failure, multi-organ failure, and coma. As far as the adult or children's and adolescents are concerned, you see more abdominal pain, nausea, vomiting, low protein tolerance or dislike for protein, failure to thrive. You see a lot of psychology symptoms too, hyperactivity, aggressiveness, delusions, psychosis. You see a lot of neurological symptoms, which are confusion, lethargy, dizziness, migraine-like headache. And I told you my example with the MMA that I diagnosed. He just came in with migraine and has tremors, very little ataxia, but learning disability, neurodevelopment delay. So you need to get all these histories to be very, very clearly available. You can have increased extracellular potassium, you can have increased extracellular glutamine, sometimes increased osmolality and inflammatory cytokines. What to do next, Siddharth?
So before we talk about KRT in these neonates, let's first talk about basics. Whenever you see a child with a suspected metabolic disorder, how do we proceed next? Next, please. So the basics are, of course, to prevent the further catabolism first. So we prevent the further catabolism by providing adequate calories, fluids, and electrolytes. We minimize, of course, the protein intake, especially for these hyperammonemic babies, and we give the energy directly through dextrose to provide alternative pathway for ammonia clearance. And these babies may require a modality of KRT, which we'll talk about for ammonia removal. Next, please. So the basic is, number one, to discontinue all feeds. So we put them off all feeds. We provide adequate calories by intravenous dextrose and lipids. It's important to maintain the glucose infusion rate at a GIR of almost 8 to 10 milligrams per kg per minute. You can start with intravenous lipid of 0.5 gram per kg per day. And once this style is stabilized, slowly you may gradually add proteins again, and in small increments of 0.25 grams per kg. Now, it's important to add, once you're thinking of hyperammonemia, to add alternative pathways for nitrogen excretion like sodium benzoate, sodium phenyl butyrate, and some of these formulations are not available in my part of the world. The intravenous formulation of benzoate is not available here. Sodium phenyl pyroate and phenyl butyrate. There are some babies who may also benefit by adding L-arginine and L-carnitine. Next, please. But in addition to this, it's important to also give supportive care for treating the associated septicemia, seizures, ventilation. And all of you do remember to avoid valproate in these babies, because valproate does inhibit the urea synthesis and can cause increased ammonia in these babies. So it's important to avoid that. Next, please. So how these alternative pathway drugs act is the sodium benzoate, it binds to the glycine and makes hippurate. And these are rapidly cleared by the kidney. 1 mole of benzoate removes 1 mole of ammonia as glycine. And next slide. If we talk about sodium phenyl acetate, it binds to glutamine, which leads to phenylacetyl glutamine. And again, it's rapidly excreted from the kidney. 1 mole of phenyl acetate removes 2 moles of ammonia as glutamine. Next, please. So in this consensus guideline from Nature Reviews, and which our group made, and we would like to suggest you this important paper where we have given you all the suggested guidelines for even the non-KRT modalities for these children. So whatever I told you, the exact doses is mentioned here in this paper. Next, please. And the recommendations are again to immediately conduct further investigations without delaying treatment and to start them on adequate calories, glucose infusion rate, which I just told you, and gradually reintroduce protein at a later date. So it's important to start nitrogen scavenging drugs, which we just discussed about, the IV sodium benzoate, phenylacetate, a combination of benzoate and phenylacetate, IV arginine, and IV carnitine. Next, please. So what next, Rupesh?
Yes. So next is, now we did everything. Patient got all the treatment that Siddharth suggested with the limited resources what you have, and the condition is getting worse because despite doing all that, your ammonia level is actually accumulating. Patient is getting more deteriorated. So now it's a time for us to start the renal replacement. Actually, the terminology has changed. It's KRT, which entails hemodialysis, CRRT, and in order to optimize concentration, you have to understand the cutoff is 400. Now, the optimal RRT prescription remains unknown. Intermittent hemodialysis achieve a small molecular clearance with diffusion and remove ammonia more rapidly than a standard CRRT prescription, which we use for 2000 ml per hour per 1.73 meters square. You need to understand that what are you dialyzing? And that goes back to the concept of seeding coefficient. How is solute distributed? Solute is distributed in a known volume, more or less bound to protein in a stable physiochemical condition. So first order kinetics. Usually in chronic patients, when you're dealing with oxalosis and other, solute undergoes variable physiochemical changes, causing it reversible accumulation. And this is something that is very important, which was inculcated in my mind by Stefan Pekka and Dr. Bunchman, is saying, this is what you're dialyzing. What are the order kinetics that you're dealing with? When to decide CBB-HDF? What are the benefits of CBB-HDF in IEM? What to do next? Prepare a hemodiafiltration if significant encephalopathy or early high blood ammonia levels are more and very early onset of disease, like day 1 or 2. So be careful. These are some of the indication. And take into account the sodium intake. If sodium benzoate or sodium PBA you're using, this could be removed very quickly out of it because these are amino acids. Now, begin the hemodiafiltration if no rapid drop of ammonia occurs within 3 to 6 hours after all the other modality and the treatment, non-RRT treatment, was Siddharth gave it to you. But you have to be careful if there is encephalopathy, high blood ammonia level, like the one in our case was 1,300 or 1,200, and you have early onset of disease, you are accumulating, then you should start preparing for any kind of KRRT.
So, Rupesh, if I may ask a question here, Rupesh, yes. Would you go for diffusion here or a combination here?
That's a very good question. So basically do what you have. Whatever is available, act promptly. Make sure you know when you're talking about early ammonia, high blood level, encephalopathy, early onset, I will do whatever is available at your site, but act promptly. If you do not see a rapid decrease in 3 to 6 hours with non-dialytic management, jump into look any kind of modality. There's no data whether it's convective, diffusive combined, hemodiafiltration. It's a molecule which is easily removed, and I showed you it's a first order kinetics. The problem is the reaccumulation or endogenous production. So that's why we are saying while hyperammonia infants are not volume overloaded, we speculate that CRRT would be a preferred treatment due to high risk of hemodynamic instability from the underlying metabolic disorders. Patients are small size and use of the drug that increase nitric oxide release and lower systematic pressure. But any modality is fine. And I think as you see, the KDIGO guideline came in very strong when these patients are very prone to the cerebral edema. So you don't like to shift the hemodynamic a lot. So prevent the cerebral edema. You can use CRRT, but my modality is whatever is you're comfortable, act promptly. Renal support, not renal replacement. Now, this is a very good slide that I want you to kind of keep in mind. These people do get some of the recirculation. So you need to calculate what is known as the extraction of ammonia. What is a systemic, what is an excess ammonia, what is systemic and the return ammonia. And you need to make sure that you calculate the level of ammonia which is removed. And my goal is It's the same as a urea reduction ratio. If you do hemo, you should be removing it around 60 to 65% on a first go with the hemodiafiltration. This is a beautiful slide that you need to know. What is the ammonia clearance and filtration fraction using difference modality? Because this is what comes back to Siddharth's question. Are you going to use the hemodialysis? Are you going to use CVVHD? Are you going to use CAVHD? And this is amount of fraction ammonia that is cleared per minute per kilogram body weight. And you can see hemodialysis remove the highest, and the ammonia fraction percentage is much higher. But the problem with hemo is you remove it and then suddenly you start seeing the accumulation because of the endogenous production. And if you go back next, CVVHD is the other one, 53 to 58%, and CAVHD. Now, CAVHD in our centers is going out of the norm. We usually do CVVHD is the lowest, it's 12.5 to 14.3. Now, this is very, very important concept that I want to bring into the thing is high dose CRRT may be performed, CVVH, CVVHD, or CVVHDF. Now, this is a high dose CRRT. Our consensus panel is for the ammonia, the panel recommend initiating CRRT in the following situation. You have rapidly deteriorating neurological status of coma or cerebral edema with ammonia level of more than 150 micromole per liter. You have a presence of shock. You have persistent high ammonia blood level of more than 400 micromole per liter, which is refractory to non-RRT medical device measures. These numbers need to be inculcated because there is a huge debate between the geneticists, the PICU, between you and the journal piece. So these numbers are clear. It has evidence. If you have a rapidly deteriorating neurological status, cerebral edema, level more than 150, trigger the CRRT or CKRT. Presence of shock with high ammonia level using all the non-dialytic management that Siddharth was mentioning. You have more than 500, 400, start the process if it's not coming down in 3 to 6 hours. Recommendation for the consensus panel, a rapid increase in blood ammonia level more than 300 within a few hours that cannot be controlled with RRT or non-RRT measures. Warming system may be used to warm the dialysate to keep hemodynamic stability. We use a higher dose CRRT, which is around 30 to 50. On an average, the adult came out to be around 50 ml per kilogram per minute of the blood flow, aiming that the dialysate and blood flow ratio should be more than 1.5, may be used for the initial therapy of patient with blood ammonia level more than 1,000. In our case, we use the higher flow because his level was around in 1200s. Then what you do is you do a step down CRRT, which can following the high dose CRRT or hemodialysis when ammonia level is less than 200 on at least 2 hourly measurements. You need to have another 200, repeat another, it's 200, keeping in mind the therapy with nitro scavenging agent may be sufficient to prevent rebound. If it is less than 200, then you have to start using the modality with a step down approach. So I don't do a high flow for a long time because you'll remove all potassium, phosphorus, patient get hypokalemic. But if you see that the levels are less than 200 in 2 consecutive sample, you go for a step down. Either you do the high cutoff membrane hemodiafiltration, go to CRRT, high flow, go back to the normal step down CRRT. Siddharth, what is the hemodialysis treatment for hyperammonia? Our center has no expertise. We do not have CRRT machine available. How do you want to treat using a hemodialysis?
Yeah, so coming to hemodialysis, and like all of us just now heard from Rupesh, and Dr. Rupesh showed an excellent table showing that hemodialysis is very efficient. However, the problems with hemodialysis are the rebound and the osmotic changes which do happen during this short session of hemodialysis. Next slide, please. So when we were talking about the guidelines here, we looked at multiple studies, and I would again repeat, since these are less patients, it's important for all of us to publish these experiences, even these are short experiences. And I would like to highlight the second study here, the study from Irvine, California, where they did hemodialysis in preterms who were less than 4 kg, and they could show excellent survival even in these preterms. I know this is a small sample, just 4 patients, but it's important to understand that intermittent hemodialysis is a good modality when you want a rapid ammonia clearance. but we need to remember that there is a risk of rebound. So the consensus guidelines do talk about initiating intermittent hemodialysis if the neurological status is rapidly deteriorating or cerebral edema. We can use, like Dr. Rupesh just mentioned, if your ammonia levels are very high, they are more than 1,000, you may use hemodialysis or a high dose CKRT, and then later on plan on step down CKRT. Next, please. So what about Rupesh, rebound?
Yeah. Good question, Siddharth. Hemodialysis to see a CRRT, prevention of the rebound. This is a problem. What happened is that, as Siddharth showed in a previous slide, that you remove the through the hemodialysis ammonia, and then it starts accumulating because still there's enzyme deficient. And you still can put the scavengers, but you start accumulating back the ammonia level. And that is a problem why we have to start transitioning from hemodialysis to CBVHD, which is a continuous removal of these molecules or this ammonia. In that case, you do not accumulate because these spikes of ammonia going up and down increases the osmolarity and toxic level, causes the intracerebral edema. Now, a lot of the people have asked me the high dose prescription. So what we do is, first, if you have hemodialysis, as Siddharth said, go ahead, use the the high cutoff membrane hemodiafiltration. Or if you have an availability where the level is more than 1,000, I will start with a high dose prescription. And I showed you the formula here. It's a pretty high dose of the effluent. And we generally do this high dose CRRT and we transition them to the regular 2,000 ml per 1.73 meter square per hour after the levels of the ammonia is less than 200 microvolt, at least for two measurement during high flow CRRT or in a high cutoff membrane hemodiafiltration. Net ultrafiltration rate will be matched to or below the patient intake and add maximum amount of phosphorus to replace the solution or dialysate, as these patients do not have hyperphosphatemia. And if you're using a heparin-based anticoagulation, use supplement phosphorus IV or internally and measure the ammonia level at least 30 minutes and then at least every 2 hours. And you keep on measuring and following the routine lab. And so this is a good prescription for you for the high dose. What are the recommendations from the consensus panel for hybrid therapy? The consensus panel suggests that CRRT combined with ECMO in severe sepsis and respiratory failures, those who are in hemodynamically unstable. The combined CRRT with ECMO increases the blood volume, allows for the use of larger cannula and allow better hemodynamic control. So that's good. You can combine the hybrid therapy. You can combine the ECMO with CRRT for these patients who are rapidly deteriorating, has an issues with respiratory compromise. As I showed you, you will see a hyperventilation, hypercapnia, respiratory failure. The way I suggest adding the ECMO is always use the CRRT, not the blood filter, because that's an old way of doing in the setting of the cardiac issues. You attach post pump and pre-oxygenated the CRRT, and this will provide a hemodynamic instability in a smaller neonate. And some of the things that you initiate CRRT right away is rapidly deteriorating neurological status, coma, cerebral edema, presence of shock, high level more than 400 micromole refracted to any non-RRT measures, and rapid rise in ammonia more than 300 within a few hours that cannot be controlled by other non-RRT medical therapies. These looks like a subtle things, but I want to make sure this has been re-emphasized multiple times during our talk. What is next? Do you write step-down CRRT prescription? Yes. Once you achieve the clearance, you start doing CRRT with the level that I said, 2,000 to 250, to 2,000 to 2,500 ml per 1.73 meters square per hour. CRRT will be continuous until the serum in the step down. How long are you going to continue the step down? Until the serum ammonia level is less than 100 micromole during at least 4 hours on at least 2 measurement. And net ultrafiltration rate will be matched to or below the patient's intake, since these patients are often polyuric and dehydrated. So you have to be careful. You need to match eyes and nose hourly rate. Metabolic cocktail clearance, keep in mind, these are small molecular weight, minimal protein bound, volume distribution. So these can be removed as soon as you put the patients on hemodialysis or CRRT. And that's why you can see the rebound coming back, because these are amino acids and they are first order kinetics, and I can remove them as soon as I put them. So make sure, are you going to rebolus them? during the time of hemodialysis or CRRT, that's kind of not yet defined. And just to show you, this was Dr. Norma Maxwell and her group in 2000 showed how much would be the amino acid loss in CVVH and CVVHD. And you can see almost a huge loss. And this is just in a normal CRRT. Talking about these kind of cocktail, you need to be careful. So that, what do you want to do with the PD for IEM?
Yeah, thank you. Since all of us heard from Dr. Rupesh about CRRT and the excellent ammonia removal in these patients, however, if you don't have CRRT, what to do? Now, I would refer you all to an excellent paper from Taiwan where they had 8 babies and they showed that PD was in fact inferior to when they compare it with CAVH and CVVHDF. And if you look at the second study here from Florence, Italy, which in fact the title of the paper was, "Is PD really out of date?" And they showed that just by doing PD in these babies from Italy, 5 out of 7 who had metabolic disorders, they did survive, and these children did had ammonia more than 1,000 at the time of when they started PD in these patients. So in our guidelines, we do mention that if you do not have other modalities, PD is recommended, ideally not from a stiff catheter if possible. And this is what we teach in all of our critical care courses, to start using Tenkov catheters, so using a softer catheter. So the consensus panel does talk about if PD is the only available modality, you should use PD. PD does save lives. So if you have a baby who has rapidly deteriorating neurological function, cerebral edema, persistently high ammonia, more than a 400, rapidly rising ammonia, more than 300, within few hours, which cannot be controlled by non-dialytic measures, you may use PD in these patients. Next, please.
So what are the prognostic indicators in this case? So as you said, Siddharth mentioned very nicely, and he has more experience than me in the pediatric at least for the PD and hemo. Some of the things you need to keep in mind, which is non-informative indicators like ammonia peak, which I have been saying since the beginning of the talk, need of the ventilatory support, dialysis mode, and type of the diseases like UCD, urea cycle disorder, and OA, except the OTC, post-treatment start coma duration. So important. So that showed you in a slide, initial response, how is predictive for a long-term outcome. Some of the things which are very informative are the total coma duration, pre-treatment start coma duration, responsiveness to the pharmacological therapy. It is so important. Now, prognostic outcome, I just want to summarize some of the studies, but want to really emphasize that PRISM score and requirement of cardioactive medications are prognostic of the patient outcome. Duration of coma before starting RRT has been reported as a significant prognostic factor. Dr. Pika showed that duration less than 33 hours is what kind of defined your outcome. And rapid initiation of medical treatment in conjunction with other therapies such as IV arginine hydrochloride and using sodium phenylacetate, sodium benzoate is also important. Now, RRT modality and the rate of plasma ammonia removal may also be associated with the patient outcome. This is studied by Schaefer and his group that showed that most rapid dialytic ammonia removal rate, right, within 50% reduction within 7 hours. You need to keep in mind, as I said, for the urea reduction ratio you use for urea ammonia ratio, I showed you the formula. It should be 50 to 60% on the first treatment. Within 7 hours, the patient survived, whereas slower toxin removal was associated with a lethal outcome. Now, they also said that hemodialysis was associated with improved survival, while delayed time to RRT more than 24 hours was associated with increased mortality. Arbiter and his group reported 18% of their continuous veno-venous hemodialysis patient died compared to 50% of those undergoing continuous PD, suggesting that the patient outcome may be associated with the RRT modality, but jury is out, it's not very sure. But Dr. Pika and patient showed in a patient undergoing extracorporeal dialysis, the duration of coma before dialysis is longer than in patient with PD, and there is no difference in short-term outcome between PD and extracorporeal dialysis. And the same study also suggested that total coma duration and plasma ammonia level before RRT are the risk factors for the death. IEM take-home messages. Take-home number 1/3 of the patient responds to the pharmacological therapy alone. Median-term outcome did not depend on the dialysis modality. A pre-treatment coma duration exceeds 33 to 35 hours is almost invariably associated with poor outcome in both medically treated and dialyzed patients, irrespective of the treatment rapidity. Siddharth, do you want to say something?
Yeah. So, like we just heard, it's about the response. So, if you have a good response within 4 hours of medical treatment, this might even help you to discriminate who will respond to the treatment, who will need dialysis. So, this point is crucial for patients who start medical therapy in a peripheral hospital, and you know that responding, because these would be the patients who would survive. So, survival, I think, depends on, like Rupesh just mentioned, on the duration of coma, and it does depend on the response within the first 4 hours of treatment.
So, in neonate hyperammonia, CVVHT-F or CVVH or CVVHT provides a treatment continuity, efficacy, and cardiovascular stability. Higher dialysis flow rate must be investigated in order to increase ammonia clearance. I think major efforts should be made on rapid identification of the patient, early start of appropriate treatment, and quick referral to the specialized center. What are the long-term outcome? What are the quality of life? These are the things that we have to do. These are very rare disorders, and it's hard to kind of assess the longitudinal outcome. But this is something people want to see now and have some questions which are unanswered. What are their long-term outcome? What are their quality of life?
So I think, Rupesh, you are the best to say the concluding message. And like you always say, it's about kidney support and not about kidney replacement therapy. And I'm just quoting what Rupesh always says, that we need to change our thought process from just dialysis, just treating AKI, to metabolic approaches and giving the kidney support to these patients. So I'm quoting just what you say, Rupesh. And thank you for leading this group. Thank you.
Thanks a lot. I will leave for the questions. And before we start question, I think that this is something that Dr. Chen wants to talk about the renewal of our 2024 IPNA membership. Dr. Chen, you want to say something on the slide?
Thank you so much, Upash, and also Sid, for the excellent talk. It's always very inspiring. And we do want to invite all of the attendees to renew or join the IPNA membership, which is very important to have your support. And at the same time, I believe we have done so much in terms of the medical education, etc., etc. We really want to include all of you in our membership, and we can benefit in the whole community of pediatric nephrology. And for those who come from low or lower middle income countries, I think there is actually reduced rates for joining the IPNA membership. So thank you so much. Perhaps Michelle, can we start with the Q&A session? It's a bit running out of time. We have about 5 to 6 minutes, so hopefully we can answer a few questions. Thanks so much. Michelle, we can't hear you. Sorry.
Now, can you hear me?
Yes.
Yep.
Okay. The first question, wouldn't adding intralipid early before diagnosis worsen FFA oxidation defect?
Rupesh, you want to go first?
Yeah, both of us can answer.
Yeah.
I think you have to also understand, these are the things that you are adding the lipid. We always said in our guidelines, you had to add a little bit later. You have to first be careful with the glucose and others. But at that time, when the patient is really going through these scavenger therapy or RRT or hemodialysis, you are endogenously clearing. So I don't think there will be a huge effect. You'll see like 20 to 30% increase. But I think it's also good for the nutrition, especially when you're using these kind of high flow CRRT, high cutoff hemodiafiltration to provide the support of the nutrition. And that's why we are saying it's a hybrid therapy. Just don't do it one time and recheck again. Siddharth, do you have anything to add?
Yeah, I completely agree with you. All the guidelines do talk about, of course, starting with a high glucose infusion rate, but they also talk about starting with intralipid, and you should give them a support of intralipid. At the onset, in the middle of the night, we don't know it's a fatty acid oxidation defect or it's a hyperammonemia or a urea cycle disorder. but the guidelines do talk about starting with intralipid in a small dose and escalating.
And you have to also realize most of the time it's the urea cycle defect or arginine and others, so you can get away.
Yep.
Thanks so much. We have two questions regarding the high flow CRRT with a dose that up to 8 liter for per 1.73 meters square per hour. The first one is whether the small filters used for neonates can allow such a high dose CRRT. And the second one is about the potential drug removal. So what do we have to do about it, especially for the sodium benzoate? If it's being removed because of the high dose, do we need a supplementation of the dosing? I think we all have these questions in our mind.
So I'll take the first one and Siddharth will take the second one. Regarding the high dose, this is some of the case series that was published. And technically, at that point of time, most of the filters, if you have issues, you can. So it's not the blood flow; it's a total effluent dose, right? You use the standard blood flow of 3 to 5 ml per kilogram per minute, but you're talking about the effluent dose. And sometimes, yes, there will be an issue with the smaller filters with the children's. So in that case, I will say that you don't go to the case reports that was published with 8,000 per 1.73 meters square per hour. You can go from like 30 to 35 ml per kilogram per hour, but not use the standard 25 because clearance with the effluent dose is so important in CRRT. The seeding coefficient of ammonia is 1, and seeding coefficient is what you're going and what is coming out. So you can remove 100% ammonia at that point of time. Go a little bit higher dose, not like 25, because it's time sensitive. Clearance is dependent on the effluent, and your seeding coefficient is 1. So that's why. But yes, I agree with you, and I technically do not go to that 8,000 per 1.73 meters square. That's a pretty higher dose. So I cut down a little bit in that case. And you can go to 25 to 30, 30 to 35 ml per kilogram per hour because it's time sensitive. But that's a very good question and concern. Siddharth, you want to take the question on removal of the scavengers?
Yeah, there are issues like Rupesh just mentioned in the talk that there are issues of you may even remove the scavengers here, and they may be you may not be delivering what you are actually giving. So yeah, but we don't have measures to look at that. But it's important to understand that yes, they may also be removed, just like the way we talk about TPN and inotropes when we start CRRT in these patients. So of course we don't have a therapeutic drug monitoring here, but it's important to understand that yes, you may not be delivering what you are actually giving.
And at that time, when you are in the CRRT mode, that's a moot point anyway because you're removing the ammonia. That was mainly for to prevent the rebound. So if you really want to, you should always do a step down. Once you are on a CRRT or hemo, at that time you're removing ammonia a lot. But there is a time frame where the patient is transferred from the center to the higher center where you get the modality. These could be used as a scavenger. Once you put them on CRRT hemo, you are at the moot point because you're removing a lot of the ammonia at that time. And if you're really worried, you can just go ahead and bolus those scavengers and put them on a step down.
Eugene, can I put Rupesh on the spotlight and ask a question to Rupesh?
Sure. But I'm afraid the time will be running because the system cut off. So please ask it. No problem. Thank you.
Okay. So just one question, Rupesh. So how do you think about the differences in management of hyperammonemia in metabolic disorders versus liver failure? So how is your approach different? I know we have a different webinar on that someday, but what's your take on that?
That's such a good question you put me on. Thank you for putting me in the spot on that one. The answer is I don't know. The practice is very different. Now, when you're talking about the liver failure, you are mainly dealing with hyperammonia because that's a triggering point, and then they need a continuous. There's a lot of other therapies, SPAD and the albumin infusion, MARS, because then you're talking about the complete end-stage liver disease with ammonia. When you're talking about inborn error of metabolism, you have to understand urea cycle of ammonia is one part of the inborn error of metabolism. There are many other toxic materials are producing. So in that case, I think they are all amino acid. They're first order kinetics. It's just the intensity and the time frame of removal. As far as the hyperammonia, issues with the liver failure, it's the intensity, but you need to be careful for endogenous production and further deterioration because of the liver failure. These two patients are so different because the other spectrum involves multi-organ system failure, brain, and circulatory support. So yes, they're totally different spectrum. And the liver failure with all, I generally prefer to go for CRRT if you have it in a center. And there are many other therapies which has been there, SPAD and others, MARS, which is not approved in the US. But that's a total different spectrum as compared to inborder of metabolism.
Thank you.
Thank you so much. So I think we are coming to the end of this very meaningful webinar. And it's also the last one for 2023. So we thank all of you for supporting us all the time. And right now, our committee is planning in 2024. So we hope to bring you more exciting webinars in the next year. Thank you so much again. Happy New Year and Merry
New
Christmas.
Year.
Yeah, thank you, Chen, for giving us this opportunity for the webinar. And thank you, Ipna.
Thank you so much.
Thank you.
As well.
Thank you so much.
Bye.